Hello, welcome everyone. My name is Katherine Twombley. I'm a pediatric nephrologist at the Medical University of South Carolina in Charleston, South Carolina. These are some pictures of my beautiful city here that I so love. And I'm here to talk to you today about LDL-Apheresis and pediatric FSGS, focal segmental glomerular sclerosis. So let's get started. So I do have a few disclosures. I am part of the FDA post-approval study with Konica for LDL-Apheresis. I'm a consultant for Horizon Pharmaceuticals. I do get an honorarium from the American Board of Pediatrics as well as the American Academy of Pediatrics. I received an honorarium from Springer for a textbook I edited, and then I have a grant with one of our junior faculty with Baxter. So the objectives of this talk are to understand the complications of untreated focal segmental glomerular sclerosis, as well as to examine the benefits of LDL-apheresis with FSGS, and then review the limitations of this treatment with LDL-apheresis. So why basically all nephrologists hate steroid-resistant nephrotic syndrome. So I spend a lot of time talking to residents about the difference between a pathological diagnosis and a clinical diagnosis. And we all know that minimal change in FSGS are pathologic diagnosis, whereas steroid-resistant nephrotic syndrome is the clinical diagnosis. And clinically, if they don't respond to steroids, it's really not a good thing. So when you look at what FSGS is or steroid resistant, we think it's an immunological process, although no one's really defined that. And it's involved with the production of plasma factors by the T/B cell combination, suggested candidates that haven't really panned out with everybody is SUPAR, ILK, and CLC1. Problem with FSGS is there's really a lot of diagnostic tools that can guide treatments. There's a lot of studies going on with this, but it's not like you can look at one child that comes in and says, you're going to respond to steroids, you're not, you're going to respond to calcineurin inhibitors, you're not. We just don't have that technology yet. Sometimes the cure is actually worse than the disease itself, and that can be a problem. There's a very high reoccurrence rate, about 50% after transplant. Tends to be lower in African Americans, but I'm gonna tell you in South Carolina, I see about equal reoccurrence rates in Caucasians and African Americans. We have tons of data on descriptive disease. We know what happens with these patients. We just don't know why. And there's very little insight into the pathophysiology or the common endpoint for this podocyte injury. We know it happens in everybody, but is this the same process with everyone? We're not 100% sure. And there's a lot of heterogeneity. It could be more than 1,000 mechanisms of podocyte injury. I like to look at FSGS, and I tell the students this all the time. You know, FSGS is kind of like a scar. Somebody has a scar on their arm. Is it because of a fire? Is it because of a cut? You never really know. It's just a scar, and that's how we look at FSGS. So let's talk about minimal change versus FSGS. So this is a picture of a kidney, right? And when you look at these, you can have little focal, so it's focal segmental glomerular sclerosis. So focal areas within the kidney that are affected, okay? As nephrologists, we put our needle inside this kidney. You have about 500 to 1 million nephrons per kidney. I stick my needle in, I want about 50. I always tell people it's about the size of an eyelash is what I'm going after. So if I put my needle here, I'm going to come up with the diagnosis of minimal change disease because I haven't hit one of these little focal circles of FSGS. So as the disease gets worse or progresses, you get more of these little focal areas. You might biopsy that child 5 years later. You hit those areas of focal segmental sclerosis, and now you get the diagnosis of focal segmental glomerular sclerosis. So people always say, oh, their minimal change progressed to focal segmental. don't know about that. I think you just sampled a section of focal segmental this time. Not that it necessarily progressed, you just didn't catch it the first time. So there's some differences, but it really depends on their clinical response. So primary FSGS is a major cause of nephrotic syndrome in children, and it's really the predominant cause of end-stage renal disease, especially in adolescents. The reoccurrence of severe FSGS in a renal allograft is a big challenge, and it's really 20 to 30%, some say as high as 50% reoccurrence rate. So it's a pretty big problem among our children. So when you think about the epidemiology, so the frequency is increased dramatically over the last 2 decades. Interestingly enough, it does tend to have some kind of geographic component to it. We don't know 100%. That really hasn't been proven in the literature. But for example, I have a partner who came from Michigan about 3 or 4 years ago, and he thought I was putting all of the nephrotic syndromes in his clinic because he had an interest in nephrotic syndrome. And he was like, listen, I've got enough. You don't have to keep giving me all of them. I was like, no, we're not giving you all of them. We just have this many. So we have a ton of children in the South with nephrotic syndrome, whereas other places might not have as much. There's a marked rise in the frequency in African-American children. Some people say there's some environmental factors. Definitely, we know there's secondary FSGS from obesity and hypertension. That's not really the ones we're talking about here today. There's also genetic mutations, and there's variable inheritance patterns. There's different penetrance and heterogosity in different of the FSGS also. KDIGO has come up with guidelines for steroid-resistant nephrotic syndrome. And they say no remission following 8-week course of initial corticosteroid therapy. You know, all of those of us who take care of nephrotic syndrome, it's really hard to keep kids on an 8-week high dose steroids because they really start getting problems with it. Usually we do closer to 6 weeks. Begin an ACE or an ARB. I typically begin the ACE and an ARB the same time I do the corticosteroids. If they fail that, then you're supposed to go to calcineurin inhibitors for a minimum of 6 months. And then it talks about if they have a partial or complete remission, you continue it for 12 months. If there's no remission, you can consider MMF or corticosteroids or consider randomized control trials. So this is kind of what KDIGO gives us. Now, problems with that is historically, we thought that proteinuria was a sign of how significant the disease was. Well, now we kind of know that proteinuria can cause damage. And which comes first, the proteinuria or the hyperlipidemia, which causes more problems? Well, nephrotic range proteinuria with normal serum albumin levels and preserved foot processes who will not respond to steroids. So the initial steroid resistance. Is this the problem? Is this what we should be going after? Because sometimes we get these kids into partial remission and we say, oh, well, it's partial remission. They're not nephrotic, so let's leave this alone. But now we know that this proteinuria actually causes damage. So albumin is really known to cause some fatty acid macropentacytosis in the podocytes. So the podocytes are actually capable of internalizing large amounts of protein through this macropentacytosis. And this process really tries to keep the filter from clogging. And when it gets clogged with all these proteins, you end up with all these elevated unbound free fatty acids. And this just starts this whole cascade of liposomal dysfunction and podocyte loss. And this is a great paper if you want to really read into that and get more of the physiology behind it. So typically, the treatment for FSGS or childhood nephrotic syndrome, regardless of the cause, we start with prednisone. Problem is prednisone can increase your lipids. Protein increases your lipids, proteinuria. Why does having protein in your urine cause increased lipids? Well, when you get hypoalbuminemic, your liver says, oh, I need to make more albumin, but it doesn't really discriminate and say, oh, I'm only going to make albumin. It makes all proteins. So it makes all your lipids too. And then you put somebody on prednisone and then their lipids get even worse. So there is some cellular uptake of cyclosporin that is decreased when the patients get hyperlipidemia. Your clearance of rituximab is enhanced via non-selective proteinuria. So you get problems, these studies have shown that patients in remission respond much better to rituximab than those who are not in remission. And tacrolimus really, you get a high-fat diet in tacrolimus, and this leads to increased LDL in its bioactive oxidized form. And then this LOX1 is the major receptor of oxidized low-density lipoproteins. And this really promotes expression of TGF-1 beta and the CTGF, which leads to fibrosis. So we always talk about tacrolimus being nephrotoxic, and now we know that tacrolimus with the high lipids is really a setup for fibrosis in the kidney. Do you remember when I talked about the cure sometimes is worse than the disease? So you give somebody steroids, and let's say you have a steroid dependent patient and they have to stay on steroids. Well, these steroids increase your free fatty acid synthetase, reduce LDL receptor, and it causes an increase in your total plasma cholesterol. And these people end up with high hyperlipidemia. Some of the calcineurin inhibitors, diabetes, tremor, they cause vasoconstriction. Now you've got hypertension. We do know that the calcineurin inhibitors and steroids can cause high blood pressure, can cause seizures from press. We've seen a few kids on calcineurin inhibitors actually develop alopecia. And of course, the steroids and the weight gain is tremendous sometimes how much weight these kids can gain. A lot of these medicines can eventually lead to chronic kidney disease along with the disease itself. So this dyslipidemia that these kids get with the treatment and the disease itself causes a lot of problems. So you have, these elevated lipids and impaired cholesterol efflux and fatty acid oxidation and impaired uptake. All of this can also lead to lipid nephrotoxicity in and of itself. So you can get glomerular injury and tubular injury from the dyslipidemia outside of the proteinuria. So it's not just the proteinuria we have to worry about. We have to worry about the dyslipidemia in these kids as well. And the dyslipidemia, the proteinuria, and the drugs themselves, all of these collectively can lead to progressive kidney disease. So you're now thinking, this can't get any worse, can it? Oh, sure it can. Just give me a second. So dyslipidemia and nephrotic syndrome and chronic kidney disease. So complications associated with dyslipidemia, look at all this. It's not just the kidneys, cardiovascular disease, atherosclerosis, myocardial infarction. All of this results from the dyslipidemia. This is not a good disease to have. So this is why we have to tackle this from many fronts. So you go, okay, well, let's see what medications we have for dyslipidemia in children. Well, when you look at your statins, we don't have a lot. The only statin that's available in liquid is pravastatin. So we don't have all these different medications that the adults have. There are studies that look at the statins that talk about the dose and how much it decreased your LDL in these. These drugs were not really meant for patients with lipids in 300-400s, because if the most you're going to decrease their lipids is by 50 points, it's a drop in the bucket when you're talking about that. Here's another study by the Journal of Clinical Lipidology, and the most they decreased their lipids in this one was like 20. So these drugs just really don't have a good effect on somebody with massive hyperlipidemia. And they're really not FDA approved in kids, and we don't really have safety and efficacy data in children. We all use them on our really bad nephrotics, but there's just not a lot of data out there for it. And then niacin, the most you're going to drop on average is 17 points. So we're just, even if you add all these together, you're not going to make a significant dent in the lipids in these children who have significant hyperlipidemia. So now what? Where do we go from all this? So there's this new treatment, and I say new, it's relatively new. The first time I used it was in 2014, but it was around before that, called LDL-Apheresis. So it's low density lipoapheresis. This is a really cool treatment. So if you look at this picture on the right, you see three columns there. The first column is your blood filter. It's kind of like a dialysis filter, but it separates the blood from the plasma. And then the second filter does the good stuff that we're going to talk about in just a second. And this is what the machine looks like. And it looks a little complicated, but it's pretty cool. So the LDL-Apheresis system separates the plasma, sends it through a filter that washes it, and then gives the plasma back to the patient. So everybody always asks, what's the difference between plasmapheresis and LDL-Apheresis? Plasmapheresis takes the patient's plasma, throws it away, and replaces it with either albumin or FFP or IgG, whatever you're replacing. In LDL-Apheresis, we're only removing the low-density lipoproteins. We're not taking away the patient's plasma. So we're not removing antibodies. We're not removing calcium. We're not removing all the other things that you normally remove with LDL-Apheresis, with plasmapheresis. So it's not immunosuppressive. So how does this work? So it has a direct effect on the LDL, VLDL, and oxidated LDL absorption. So long story short, I'm going to go through some of these, but we don't 100% know the entire mechanism of why this works. We know that this plasma filter has these cellulose beads that are negatively charged, and it pulls all these LDLs to it. So what does this do? It decreases your LDL. So if you don't have as many lipids, your drugs work better. You don't have as many protein binding issues with the drug. So we do think it makes your body sensitive to the medications itself. It has some vasodilatory and anticoagulant effect by absorption of various pathogenic factors by dextrose sulfate. So it can increase your VEGF, your nitric oxide bradykinin production, absorption of vascular permeability factor. And like I said, it enhances your immunosuppressant response by improved intracellular drug transport. So the initial studies done by Hattori et al. Talked about how patients who were steroid resistant, after going through LDL-Apheresis, they all of a sudden became responsive to the corticosteroids, and they're thought that it just allows the drug to have intracellular transport better. So this was first described in 2003 in an AJKD paper by Hattori et al. They looked at children with steroid-resistant FSGS with this treatment, and then the FDA got involved and it got approved in the US. So the initial post FDA approval study was children less than 21 years of age. I think the youngest to date is 6 years. I might be wrong, but when I did this slide, that was the youngest. They need to have a GFR of more than 60. At the time of the initial study, it was looking at children more than 21 kilos, but in 2016, they decreased the age to 18 kilos. The way this treatment is done is you do 2 sessions a week for 3 weeks, and then 1 session a week for 6 weeks. Now, in Hattori et al.'s paper, when they started the weekly sessions, they went ahead and started prednisone at 1 milligram per kilo per day and kept that through the 6 weeks of the weekly sessions, and then they weaned it off afterwards. Now the FDA does not have a requirement to put prednisone there. It's up to the discretion of the provider. So I want to go through a couple of patients that I've treated with this and kind of give you some lessons learned and things I've learned and tips and tricks and things like that. So the very first patient I ever did was a 4-year-old. She came to me for a second opinion in 2015, but she was diagnosed with steroid-dependent nephrotic syndrome in 2012. In March of 2013, she was started on tacrolimus. She had some problems with the tacrolimus, so she was switched to cyclosporin. And then she never went into remission with that. Excuse me. And so they put her on a course of PO Cytoxan. They decided to biopsy her. She had minimal change with 5% global sclerosis, no interstitial fibrosis or tubular atrophy. So after she completed the Cytoxan, she was still in relapse. So they put her back on Prograf, and they increased the target of the Prograf, and she went into some partial remission. But then later that year in April, she was completely multi-drug resistant, no longer responding to steroids, but had a completely normal GFR. So later that year, the parents, or early the next year, the parents decided to come see me for a second opinion. So I had a 20-kilo kid. And you remember at this time, post FDA approval was for 21 kilos. She came to us in really bad AKI. She had really bad anasarca, just swollen everywhere. Decided to shut down her kidneys, not pee. And there we were. So we admitted her to our ICU. We put a catheter in her. We gave her, started CRT, gave her a dose of rituximab. And you could see her serum creatinine just kept going up and up and up and up. About 2 months later, we said, okay, nothing's working. We're going to try this new treatment that I just heard about at a conference. And we had this machine because our adults use it for the familial hypercholesterolemia. And I said, we're going to try this, even though she's too small and has AKI. And sure enough, I put her on this with MMF because she had never been on it. And as you can see, she pretty quickly went into remission. Her lipid panels were crazy sky high. Her triglycerides were 400. When you look at the pre LDLs, they were pretty high, and they kind of got high towards the end too. But her urine protein creatinine when we started treatment was incredibly high. And then you can see here over the past several years, she's went into remission. This was her on her last day of treatment. And she was so excited to get her line out. And I just saw this child about 3 weeks ago. She's not a child anymore. She is a full-fledged teenager with attitude to match. And she just relapsed the first time since 2015. And so she's been in remission. So while it wasn't the end-all be-all cure, it did keep her in remission since January of 2016 until January of 2023. So for me, that bought me a lot of time on her, on a kid that had pretty much had the kitchen sink thrown at her before she got to me. And some of this, I really do think it's because we were able to lower her lipids enough for some of the drugs to work. We were able to get her out of renal failure. This is her when we first got her. And like I said, you would not recognize her now if you saw her, but she just had her first relapse. So for me, that was pretty good. So I learned there is utility in using this treatment with AKI. It can be used in smaller children. And in 2016, the weight limit was decreased to 18 kilos. And the reason they limited it to 18 kilos is because of the extracorporeal volume of this machine. If you get lower than 18 kilos, you have to blood prime. So if you're talking about a kid who's going into transplant at some point, the last thing you want to do is, load their circuit with a fresh set of blood, for that many treatments. So, but like I said, now I can say she was remission free, or she was relapse free from late 2015 to early 2023. And we did publish this if you want to read her story. So our next patient was a 9-year-old African-American female who presented in May of 2017 with new onset nephrotic syndrome. Mom also has FSGS. We still to this day, we've been unable to get a good picture of whether mom's is obesity and hypertension related or whether it's genetic, but she's a single mom with 8 kids. None of the other kids are affected. So the patient was started on steroids at 9 years of age. A month after steroids, she got a terrible abdominal cellulitis that you can see here and peritonitis. And also on this admission was diagnosed with steroid induced diabetes. So, it became clear at this point, after a month, she was not responding to steroids. She had significant complications for it. So we had to get her off. She did have an AKI. Her creatinine was up to 1.3. And she was incredibly diuretic and fluid resistant. We could not get the fluid off of her. She was just so difficult. So we placed an IJ in her for chronic albumin and Lasix infusions. And we were ready to, to think we were going to have to declare her. Unfortunately, when they placed the line, she coded. She was just so incredibly fragile. And, she ended up having fluid around her heart. But she recovered from that. And then we ended up doing 3 times a week albumin and Lasix infusion as an outpatient because we went through a bunch of medications and she didn't respond. So if you look at her, she started prednisone here. She got biopsied and was thought to have minimal change disease. She got rituximab times 2 and started MMF. She had 11 admissions in 8 months. She spent 105 days in the hospital after this. Okay. All these little stars are representing admissions. We started LDL-Apheresis here. And she got so incredibly diuretic resistant that she would wake up at night thirsty because she would get so intravascularly dry and would drink from the sink. And we actually had to turn the water off in the room because she would tiptoe and not even wake mom up. So it was really kind of impressive how much she would drink. And so all these stars are admissions here, 105 days in the hospital. This is when LDL-Apheresis ended. This last little star here is she had her central line in and she got E. coli sepsis. But because her albumin was starting to go up, we treated her, took the line out, and she went into remission after that. And so I wanted to show you what these lipids look like pre and post. So if you look, the triglycerides, it really reduces them significantly. The total cholesterol on the right, one time it took her from 600 to like 120. It really does significantly reduce your lipids with this, giving the drugs time for them to work. So what did I learn from her? You really have to watch your immunosuppression while putting in a central line. I mean, that's common sense, I know, but I mean, this child got, bacteremic and septic. So we really did have a problem with it, but she went into remission, got her albumin up to 4, but it was really a partial remission. She still had proteinuria, maybe not nephrotic, so that her albumin went up to normal, but she no longer had to have 3 times a week albumin and Lasix infusions after this. So it really did lead to decreased healthcare utilization and probably she started dialysis, I think in August of last year. So it really gave her several years of being out of the hospital and being in school and just being a normal kid for a while. So our third patient is a 3-year-old male with nephrotic syndrome diagnosed in 2011, resistant to steroids. He had a biopsy in 2012. That was minimal change. So they added MMF. There was no response. Weaned steroids, started cyclosporin. He responded within a month beautifully. 2014, the family decided to self-wean the cyclosporin because he was doing so well. And then in 2015, he relapsed. They started steroids again, and this time he did not respond. They restarted cyclosporin. He responded, but was only in remission for about 3 months. And we kind of suspected at that point there was some poor compliance there. In 2016, he had a partial response to steroids and then progressed where he didn't really respond to cyclosporin, started having problems with the cyclosporin. We gave him rituximab twice. He never responded. We did LDL-Apheresis. He did not respond. His biopsy right before we started LDL-Apheresis, he had 37.5% glomerular lesions. He had no interstitial inflammation, mild IFTA, but eventually we ended up taking out his kidneys in 2018. So a couple of things on this child. So this is a port. This is a, I think it's called a vortex port, but regardless, it is a double lumen port. That was really a game changer with him. So, we hate using PICC lines and IJs, and I know this goes into the subclavian, but it's a 9-week treatment. And so this really worked out well that we were able to use this double lumen port for not only albumin and Lasix, but we were able to use it for his LDL-Apheresis treatment also. So this was a huge game changer for this kid. And this is actually his x-ray that you can see with that port. It's a pretty big port. I don't know that the pictures do it justice, but it's a pretty significant size port. So you can't put it in little kids. Unfortunately, we listed this kid for transplant, which is the good thing, but he ended up getting an accidental ABO incompatible transplant in 2018. Yes, I did say that, and I can tell you how that happened offline, but he got an incompatible, and we had never done an incompatible, so we had a lot to learn. So an O patient gets an A, deceased donor kidneys. Fortunately, his titers were not that high because he had had rituximab, so we almost, in an essence, desensitized him a little bit. We induced him with thymo and solumedrol. 12 hours after transplant, he had a urine protein creatinine ratio of 18.4. So, of course, we started Plex immediately after transplant because he reoccurred and because he got an incompatible kidney. So the orange line is his serum albumin. The blue line is his creatinine. So you can see he did have a little AKI after getting this incompatible kidney. We gave him thymo, steroids, Plexting. His creatinine decreased beautifully. His albumin increased rather quickly. So he got plasmapheresis. I did give him 4 doses of rituximab. And then I started, so he did not go into complete remission with plasmapheresis. And the reason I went straight to plasmapheresis was because of this ABO incompatible. So once we had him out of the, urgent range for the ABO incompatible, he still wasn't in remission. So I decided to go ahead and start a round of LDL-Apheresis. And by the time I stopped, he was in complete remission. And as you can see, his urine protein creatinine ratio has been 0 ever since. And he just hit the 3-year mark. He is in complete remission and never had a relapse after his LDL-Apheresis treatment. Now, so things I learned here, LDL-Apheresis can work when Plex does not. Interestingly enough, my hypothesis for why LDL-Apheresis did not work pre-transplant is because it was almost like one of those last-ditch efforts. So if you wait until there's too much glomerulosclerosis, the damage is done. So it doesn't matter what you hit them with, they're not going to respond. But after transplant, we started it pretty quickly within like 2 or 3 months. And so I think if you're going to use this treatment, you need to start it early rather than wait until all these other medications have failed and they have the complications of the hyperlipidemia and everything else. We learned about the double lumen port, which we've used several times since then. And then why do some respond, why some don't? So this is back to that Hattori paper when they looked at 11 papers and talked about the renal biopsy of these patients. Some went into complete remission, some went into end stage. And it really kind of boils down to, those who went into end stage had higher glomeruli with global sclerosis at the beginning of the treatment. So I do think, and they actually had higher tubulointerstitial scores too. So I do think there is something to that of, if you wait too long, it doesn't matter what you treat the patient with, it's not going to have an effect. This just kind of looked at the onset of LDA, the age onset of the nephrotic syndrome versus onset to LDL-Apheresis and what prior treatments they'd had. And the other thing this showed was the lower the GFR, the less likely they are to respond. Now, I do think this is chronic GFR because, like I said, my patient had an acute decrease and responded well. So when you look at Tori et al.'s paper, just kind of to summarize, they looked at the serum cholesterol. I mean, these patients had cholesterols 483, 519, really, really high, and the glomerular lesions and the tubulointerstitial lesions. And it's just, comparing the ones with complete resistance to failure, it was just impressive about how worse the failure patients were than the remission patients. So my patients, so I gave you 3 patients. Patient 1 had glomerulosclerosis at 5.6%, completely responded. Patient 2 had a partial remission and had no glomerulosclerosis. Patient 3 did not respond, but had 37.5% glomerulosclerosis. Patient 3 post-transplant had 0 glomerulosclerosis at the time of treatment. Tubular inflammation, none of my patients had tubular inflammation. My first patient had some mild tubular inflammation, but that was it. IFTA, my first patient had moderate IFTA, which was surprising. Patient 3 on the native biopsy had mild, but there was so much glomerulosclerosis, I think that's what did him in. The GFR on my first patient was very acute at 17. My second patient, partial remission, had a pretty good GFR at 87. My third patient, prior to transplant, had a GFR of 22, and that was chronic. That was not AKI. So I think that's, where that patient failed. But post had a GFR of 67, which is pretty good for a single kidney post-transplant. And the biopsy, it doesn't really matter. Minimal change, FSGS, recurrent FSGS, and I showed on that slide with the biopsy why that really doesn't matter. So final lesson learned, all of our children are different. Some are going to respond, some aren't, but I think we still have a lot to tease out as to who's going to respond to LDL-Apheresis, who's not. So that's kind of what I have for you today. I'm happy to take questions. Thank you for the opportunity to do this. You want me to stop sharing?
Hi, everybody. I just want to say I'm the moderator. I came in late and I apologize for some technical difficulties, but that was a great talk. And if the audience has any questions, either you can put it in the chat or Q&A, or actually raise your hand, and we can have Dr. Twombley address it. So maybe I'll ask you a question. So,
Sure.
You talked about the post-transplant FSGS that recurred, you used the plasmapheresis, and 2 or 3 months later, you did lipid LDL-Apheresis. Were the lipids very high before you did the apheresis, or were the lipids normal? And if they were normal, then what is the mechanism by which the patient went into remission?
They weren't normal. They weren't 400 or 500 because we were doing plasmapheresis, but they were high. They were probably more in the 200 to 300 range when we started, because the serum albumin wasn't normal at that point either, and they still had low grade, nephrotic proteinuria, like maybe 2 to 2.1 urine protein creatinine ratio. So enough where they weren't incredibly symptomatic from an edema standpoint, but enough protein that I knew if we left it, they would get in trouble down the road.
Mhm. So in that case, if the recurrence occurred immediately post-transplant in a patient who has previously been nephrectomized, and let's assume that, the lipids are normal because the patient had the nephrectomy, let's say a few months before transplant, do you expect LDL apheresis to work for those patients who recur right after transplant? Who have a normal lipid panel?
I do, and I've used it many times now. So I was always hesitant to do LDL-Apheresis post-transplant, because when you do plasmapheresis, after about 3 or 4 treatments, you start seeing a change. You see the protein going down. But with LDL-Apheresis, it's not an immediate response. Some patients respond immediately within 2 weeks. I've had some patients that don't respond until the week after. I think some of that we're going to be able to tease out once we look at a larger number of those patients to see why some take longer to respond. I think some of it is the degree of hyperlipidemia, that it takes more than one treatment to get it down. But even the patients who don't have high lipids, I think the benefit of doing this treatment is you keep them from having high lipids. So the question becomes, would plasmapheresis do the same thing rather than LDL? And I don't really know the answer to that. I don't know that anybody does. The benefit to the LDL is you don't immunosuppress them more than you already do. And plus, you don't have the risk of the bleeding complications that you can have with plasmapheresis because you aren't removing all of that. So for me, it's a little bit safer post-transplant just because I don't have those 2 added complications that I have to worry about, especially in a kid that I'm giving thymo to, to do plasmapheresis and immunosuppress them even more always worries me.
Thank you. Does the audience have any questions? So then maybe I'll ask one more question. So, after you do LDL apheresis, let's say they go into complete remission, they always have to be on some immunosuppressive drug after that, right? Is that correct? Okay.
Oh, well, so I think the verdict is not out on that, right? So there's some, it's kind of like rituximab, right? You give rituximab and, some of the data shows that you put them on like CellCept because it makes them respond better to medications. So I have children that I've done LDL apheresis on that I have not kept them on anything other than an ACE and ARB at parental preference, and they've done okay. But I've had some kids that I'll put them on something like MMF or steroids while they're on the apheresis, and they go into complete remission. And then once they're off the apheresis, their lipids go back up because of the steroids or the tacro or whatever, and then they relapse again. I have tried MMF with some of these patients because it doesn't tend to have as much of the hyperlipidemia response. Those kids tend to do okay if they can tolerate it and don't get the GI side effects from the MMF. So I think that part is up for debate as well. But I do have kids that I've given it to and not given immunosuppression that have responded and stayed in remission for a while. Wow,
that's good to know.
But like I said, I can't tell you who is and who isn't.
Right. Well, nephrotic syndrome is so challenging, and each patient is so different that you got to go with individual responses.
Absolutely.
So I guess we don't have any questions. Oh, there is one. Yes. So what is the best time to start LDL apheresis? I don't know who asked that question, but I guess you can answer it.
Yeah. So I think that's the $50 million question, right? I still start everybody on steroids. steroids because a large number of children will respond to steroids. If they don't respond to steroids, I typically give them a short course of either a calcineurin inhibitor or MMF. And by short course, I usually mean about 6 weeks. If I haven't seen any response in 6 weeks, I give the families the option of LDL-Apheresis if the patient is over 18 kilos. If they're under 18 kilos, it's not really an option because it's not FDA approved for that group. But if they're over 18 kilos, I give the data to the family and I let the family make the decision. You know, rituximab's not benign either. You know, I mean, it comes with a lot of complications, and we don't know the data on giving kids rituximab every couple of years, you know, while they're developing their immune systems and are, you know, naive to a lot of infections versus putting a central line in and doing LDL apheresis for 9 months or 9 weeks. You know, I was actually kind of surprised when I started giving families the option. I'm surprised how many people go with the LDL apheresis. I just thought people would go, oh, they got to have a line, they got to have surgery to have the line, then have another surgery to take it out. Families are much more against immunosuppressive medication and the complications of it than they are with the LDL apheresis. But I leave it up to the family because we don't know which one's better. And we don't know what the right answer to that is. And so I give the pro and cons and tell the family I'll support them either way.
So it looks like we have a second question. Comment from Japan.
Mm-hmm.
In adult case, the earlier the start is the better. So
I totally agree.
So
if you're going to do it, it doesn't need to be a last ditch effort. If you're gonna do LDL apheresis, you need to do it before they have a lot of fibrosis and glomerular scarring.
Dr. Muso, do you have any other comments to her question?
I don't know if the participants can speak. Yeah. It might be muted.
Okay. Well, he didn't answer anyway. So I guess if there are no other questions, we could end the session then.
Yeah. Well, thank you for the opportunity to give this talk, and I hope y'all enjoyed it, and please feel free to email me with any questions.